Welcome to those of you who've just joined us. We're just going to give it a few more minutes to let everybody sign on before we get started. Okay, well, it looks like that we're at the top of the hour, so we'll get going with today's webinar. Welcome, everyone. My name's Fiona Lewis, and I'm the Patient Support Liaison for AMAC. And I'm very pleased to welcome you to this webinar. AMAC is a leading funder of research into bone marrow failure diseases in Canada, and I invite you to visit our website to find out more about our services across the country. Your line will be muted during today's presentation, but we do invite you to type any questions you have into either the chat feature or the Q&A feature, and you'll find those if you hover your mouse over the bottom of your screen. So we've got about half the session today, about half an hour to answer questions. And if there are any that we cannot answer by the end of the session, I will commit to sending those by email to the presenters, and we'll try to get an answer for you later. This session will be recorded and will be posted on our website. So I'm pleased to introduce Danielle Moch and Dr. Dwip Prajapati to present today's webinar regarding MDS treatment. Danielle Moch is a program lead for Community Cancer Care Coordination for Cancer Care Alberta. Danielle completed her Master of Nursing in 2020 from the University of Alberta. Her nursing background has included medical oncology, malignant hematology, radiation oncology, and cancer patient navigation. Danielle was the recipient of the Canadian Nurses Foundation AMAC Award for the academic year 2019-2020. She is dedicated to enhancing patient-centered oncology care and supporting care closer to home. Dr. Prajapati is a clinical assistant professor at the University of Calgary Department of Oncology. He completed his internal medicine residency at the University of Saskatoon and his hematology residency at the University of Calgary. He received his Royal College of Physicians and Surgeons of Canada Fellowship in Hematology in 2018. Dr. Prajapati commenced his appointment as a hematologist in Central Alberta Cancer Centre in Red Deer in 2018. He also has his professional practice for benign-related hematological conditions in Red Deer. He has received numerous academic awards, including Junior Resident of the Year. He has completed research projects, having a keen interest in hematological methods of care in emergency departments, and further interest in quality assessment and improvement projects. Dr. Prajapati is dedicated to developing the working team environment and enhanced care for patients. He provides educational learning sessions for healthcare professionals on hematology topics. So thank you to both of you for being here today. And with that, I will turn it over to Danielle to begin the presentation.
Thank you so much, Fiona. And while while my other colleague, Courtney Walls, will not be presenting in this presentation, she did assist with the content, and she is a pharmacist that we also work with, and we're thrilled. And I am so thankful to be here and to be speaking with all of you. And I'm very grateful to my colleagues, Courtney and Dr. Prajapati, for being here as well with me as a team. So thank you so much. We're going to jump in. So today's topic is MDS treatment and side effect management of MDMS. And as well at the end, we have an Ask a Hematologist segment. So please feel free to type your questions into the chat, and we will answer those. Well, and by we, I mean Dr. Prajapati. Yes, we will get those all addressed. And as Fiona said, if there isn't enough time, I will tackle those offline and try and get you a response. So here we go. Okay. Okay, so we're just going to jump into a quick overview of MDS. So myelodysplastic syndrome, it describes a group of disorders that affect stem cells, which are basically immature cells that can form all types of different blood cells. So these disorders, they begin in the bone marrow where these cells are made. And a blood stem cell can become either a lymphoid stem cell or a myeloid stem cell. A myeloid stem cell turns into a white blood cell. And then a myeloid stem cell turns into either a red blood cell that carries oxygen throughout the body and other substances to all tissues, or it can turn into a platelet, which forms blood clots. It stops your blood from bleeding, or it can turn into a granulocyte, which is a blood cell that stops and tries to prevent and help fight infection and disease. So the most common affected people of MDS, it's more common in our elderly populations. The average age of diagnosis is around 70 to 75 years old. Less than 10% of patients are under the age of 50 years old. So it's definitely more common with, with our older populations. It's common in people who have worked in agriculture or industries, working around pesticides and things like that. And I'll get into that a little bit further. The prevalence is 2 times higher in males than females. However, it is more common for females to have this chromosome P5 deletion, which we will get into a little bit further. And really, this P5 deletion, it's going to determine some treatment approaches, and so there are some different options whether you have it or whether you don't have it. So the main common side effects of MDS include shortness of breath and feeling tired. It can progress to acute myeloid leukemia in about 1/3 of people. Now, when I was doing the research for this, that number seems to vary depending on where you find information about this. It's higher in some journal articles and it's lower in others. So just on an average, about 1/3 of people will go on to develop AML. Other side effects include fever, frequent infections, easy bruising and bleeding, fatigue, shortness of breath. And shortness of breath is really related to the blood. So as the blood counts, the red blood cells start to deplete, there isn't enough oxygen being circled throughout the body, and this can make you feel very tired. So those are definitely the most common, although you can also have some abdominal discomfort or, feeling, very full in the abdomen and just generally feeling unwell. So when our blood counts are low, our red blood cells, we call this anemia, and that is a condition in which you lack healthy red blood cells to carry that oxygen to the body's tissues. So we're going to get into that a little bit further on the next slide. So there are multiple types of MDS. I've listed 6 here. There is an additional one. It's called de novo myelodysplastic syndrome, which basically means that it develops without any known cause and it doesn't fit into any of these other categories. So there are definitely multiple different types, and there can be different challenges in the blood. So refractory anemia, so affecting the red blood cells. There can be different things seen under the microscope, which are these ringed sideroblasts, or excessive blasts. So really we're trying to take a look at how funky does the blood look, how does the bone marrow look, what is in there, are we seeing more red blood cell challenges, I guess you could say, or changes, are we seeing more white blood cell changes, what we're really just trying to figure out what's kind of going on in there. And yeah, so that's why there are so many different types. Some risk factors for developing it. It can include high dose radiation, whether that's treatment based or maybe location of where you live. Some genetic conditions can cause this, so that workplace exposure, as I mentioned earlier, to industrial chemicals or rubber and benzenes and things like that. Smoking cigarettes is definitely a risk factor. There are certain chemo and radiation therapy regimes that we give for other types of cancer that can increase the risk of MDS, although this is quite rare. And then as well, if you've received an autologous stem cell transplant, which basically means you had a transplant with your own cells that we put back into you, can be a risk factor for developing MDS as well. So some of the treatment goals for MDS, they really do depend on a few different factors. So, what are our goals? Are we trying to relieve symptoms? Are we trying to slow or stop the spread? Or, stop the spread from turning into AML? Are we trying to improve quality of life? And often we're trying to do all of these things to really help. You may be offered a combination of different treatment types for very low and very low or low risk, intermediate risk. Sometimes the goals may be to improve transfusion dependence, so where you don't need to go into your local hospital or clinic for regular transfusions. Some of our goals for higher risk disease might include preventing that AML and improving your survival. We're really looking at slowing the spread and improving quality of life. And these are discussions that, with you and your physician, that will help determine, what are you hoping to get from these treatments. So as we get into the treatments, there's multiple different options. So we have here monitoring. So that's what we consider watchful waiting, every 3 to 6 months with different blood work and physical assessment. And I'll get into that a little bit more. There, could be stem cell transplants. We might be giving growth factors. There's a variety of different drugs that we can give as well. Those transfusions, whether that's red blood cells, or platelets, or both, just depending on, what kind of needs, what do we need to do to make you feel your best and live your best life, and as well, clinical trials. So how do we decide? So there's a few different factors that we take into consideration when we are looking at, treating. So these are, your age, your performance status. And what we mean by that is, if you're a very healthy 70-year-old, you run marathons, which I personally can't do, versus, a 70-year-old who might have a little bit more health history, maybe not as physically fit, can't get, needs more support for those daily livings and, just getting, basic care done. So there's a difference between that we're looking at to see, okay, well, how well are you going to tolerate these treatments that we're offering? or that you might be offered. So we're looking at that presence of comorbidities, which means, how many diagnoses do you have? Are you taking a bunch of medications or other treatments for other diseases? And in which case, that it might be fine, but we might need to look at drug interactions and, effectiveness of our treatment versus other things that you're taking as well. And then your personal preference. Other things that we look at are, your caregiver support and the possibility of there being a donor available for transplant. Should you be well enough or, fit into the certain criteria within your areas for that. So in order to figure out what kind of treatments you might be offered, there are a variety of different disease classifications and calculators that can be used. So there are, when I was, going through my research for this, there's definitely a handful. There are definitely preferred scoring systems that will really look at you particularly and what is in your blood and your symptoms, and really trying to classify your risk of progression and your risk to acute myeloid leukemia. So some of the things that these look at are, the percentage of blasts in your bone marrow. So incomplete cells, or they're just bulking up that bone marrow. So again, like how funky is the bone marrow looking? And yeah, so that's one of the ways that we can score this. Another way is or in addition is a karyotype, so which is basically looking at your individual collection of chromosomes. So I mentioned earlier that P5 deletion chromosome. So we're looking at, do you have that? Do you not have that? There are other chromosome changes that are also taken into consideration. And we're looking at your hemoglobin levels, so those red blood cells that carry the oxygen. We're looking at the platelets that clot the blood, and we're looking at the absolute neutrophil count, which are what help fight infection. So all of that is taken into consideration to determine your risk for further progressive disease, and also what treatment options are available for you. So I have, for this presentation, I have classified as lower risk MDS and higher risk MDS, and we will go into the treatments for both of those. Okay, so I really like this. I'm just going to see if I can. Oh, I'm so sorry. It does say lower risk here, MDS at the top here. And this is basically just a flow map that can be used to help your provider figure out, based on your scoring and your calculated score of your MDS, what treatment options might be available to you. So are you symptomatic? Can a stem cell transplant be available? Which, basically means that we take these immature cells from somebody else and put them into you to become whatever your body needs them to become. If you're symptomatic, depending on what symptoms you're having, you may be offered treatment. If you are asymptomatic, and maybe this was an incidental finding, so you went into the hospital because you actually, I don't know, you hurt your toe, but they decided to do blood work and they found this, but you're asymptomatic, they may not do anything at this point. They may just watch you and just see how you do. And that would be through physical assessments and blood work regularly. If you are symptomatic, they're going to look at, okay, well, what kind of symptoms are you having? Are you bruising? Are you bleeding? Are you short of breath? Are you tired? And taking a look at that. And based on these things, there's going to be a few different treatments that are offered. So do you have this P5 deletion? If you do, you might be offered ESAs or lenalidomide. If you don't have that P5 deletion, then you might be offered immunosuppressive therapy, which I will get into these treatments in much more detail here. And then if your disease progresses after these treatments, then you may become more high risk. And we will go over those. After. So we're going to go on to our lower risk treatment options, which include growth factors, the watchful waiting. They may include blood transfusions, which could include red blood cells and platelets, immunosuppressive therapy or cytotoxic therapy, immunomodulating agents, clinical trials, could be supportive care and in addition with plus or minus antibiotics to help fight infection. So if we go into growth factors first, I love this picture. I do. This is what I think of when I think of growth factors. So there are a couple different types of growth factors. There are growth factors that will help stimulate the bone marrow to stimulate more red blood cells. And there are growth factors that will help stimulate your white blood cells to help fight infection. So these ESAs are red blood cell growth factors. There's a couple different brands or types. So there is this epoetin alpha and this darbepoetin alpha. I often just refer to that as Darby, and I know this as EPREX. So we'll get into that a little bit more first. So the ESAs, so these are a type of treatment. They can be given subcutaneous under the skin. They're usually filled at your local pharmacy. They don't need to be given by a special pharmacy or at your cancer center, and they can just be injected at home. They aren't without risks though. So usually the purpose of the ESAs are to increase your hemoglobin so that you will not need transfusions. When your hemoglobin falls under 100, that's usually when these are given, but it's not without risks. So it sounds wonderful. It sounds very easy, where you might be given this weekly or every three times a week. But there is significant risk for some clotting issues with this. There could be thrombolytic events or stroke. And so it's really just weighing that risk benefit and that patient preference as well. Like if you are one of those people that says, there is no way that I'm going to come to the clinic to sit in a chair and have a transfusion over 2 to 4 hours regularly, I'm just going to take this because this is better for my quality of life, then that is a conversation between you and your provider to discuss those risks, benefits for yourself. They're going to be different depending on who you are. And with these, you might also need to take an thrombotic prophylaxis injection, which basically means that we are going to help thin the blood a little bit so that you're not at significant risk of, your blood clotting and, those strokes. So that is a way to decrease that. That is another subcutaneous injection. So this treatment for somebody who doesn't like needles would probably not be, the best. So I will just keep going. This is a new drug. It's a second-line therapy for transfusion-dependent patients. It is as well subcutaneous and it's given every 3 weeks. It is for patients without the chromosome P5 deletion. So when we would give this is when those ESAs to stimulate the red blood cells, they aren't working. This could be an option for you through compassionate access. And compassionate access just means that the medication has not been accepted for public funding yet. So the drug company pays or co-pays with your own private plan. Some of the more common side effects with this drug include fatigue and headache. You can have some muscle and bone pain, dizziness, and there is also an increased risk of reaction, so which is what we call a hypersensitivity reaction. That's over 10%. So that is more high risk for having a drug reaction to this. So the filgrastim and pegfilgrastim are the GCSF growth factors, and those are the ones that stimulate the white blood cells to fight infection. It is another subcutaneous injection given under the skin to help reduce infection or help fight infection. This medication in particular can cause a lot of bone pain, which can be treated with analgesics. and it can be injected at home or by your local pharmacy as well. If we go into watchful waiting, which I mentioned earlier, these are the things that might be included in that assessment. So every 3 to 6 months, you're probably going to have some blood work done, a physical assessment done. They may look at, they'll want to see how the blood is looking and do that blood smear. And if there are changes in the blood work that are observed, they might, beyond supportive care measures, you may be, having that discussion about whether or not a bone marrow aspiration and biopsy is necessary for you, and whether or not that's something that's in line with your personal preference and, your treatment goals. Changes in your blood might include some cytopenias. So, where we're seeing low blood counts, whether that's red blood cells, platelets, white blood, all that stuff, everything. And they're also going to want to see if there's any circulating blasts that are noticed. So blood transfusions, which this is typically the standard of care for many patients with MDS. Most physicians will transfuse, or most physician preferences is that they'll transfuse when your red blood cells become lower than 90, although some have different variabilities. So some will transfuse under 80, some will transfuse under 70. It just depends on you, your symptoms, how you're feeling, and usually, physicians will transfuse your platelets when they are under 10. Although, again, this may be symptomatic, depending on your symptoms and, how things are going on your care trajectory. And transfusions may become more and more frequent, transfusing regularly every 1 to 2 weeks. And sometimes that number will even increase to every few days as needed. So immunosuppressive therapy, this can be offered in certain cases. It is basically, it is a type of treatment where we give prednisone, we give the AGT, which basically stands for anti-thymocyte globulin. It is given in hospital, and it is given on a specialized nursing unit. So basically how this treatment works is it stops by, it tries to suppress the T lymphocytes that are attacking the bone marrow stem cells. So it tries to reduce those so that your stem cells have a chance to regenerate. It is typically followed by 6 months of cyclosporin A, which again just stops those T lymphocytes from becoming active. And it is a tougher treatment. It does have a lot of side effects. It is given intravenously into an IV or a PIC or a port every 8 to 12 hours for a day for 4 days. And just depends on the provider and the patient as well. And these are some of the common side effects of that. Now, if you are going to see any kind of treatment response, it's usually as early as 3 months. It could be as late as 9 months, though, for that treatment to work. The other medication is lenalidomide, or you may have heard of it as Revlimid. It is given for low risk MDS with symptomatic transfusion dependency. And it is taken for 21 days orally on a 28-day cycle. It is given to people with the chromosome P5 deletion. And There is regular monitoring, regular blood work required, and it must be dispensed by a RevAid certified pharmacy. And there are I wouldn't say there's very limited number of these pharmacies, but they are more of a specialized pharmacy within Canada. And the purpose of this pharmacy and the reason why they don't just have anybody dispense it is because this medication has significant birth defects. So it is part of these pharmacies' responsibility to prevent that through education. And so there are certain courses that these pharmacies need to take. And that's just a bit of FYI for you. It's nothing too crazy. It's just every time that you pick up this medication, your pharmacist will talk about your sexual health with you. Some of the side effects include rash, fatigue, and if you are lactose intolerant, you may experience some regular diarrhea on this medication. Another treatment that you might be considered for is a clinical trial. And a clinical trial is basically just a research study performed in people aimed at evaluating some sort of medical, surgical, or behavioral intervention. And all MDS patients are typically considered for a clinical trial. There are 4 phases to clinical trials, and I don't want to get too deep into this, but the first phase, phase 1, is usually given on a very small group of people, and it's to judge the safety and the side effects to find the right dosage for that medication. So phase 2 clinical trials, they really focus on the effectiveness of that treatment. And phase 3 is just working on gathering more safety information, effectiveness in a larger group of people. So these are usually in the thousands. They're usually ongoing studies for years that are just really looking at that effectiveness and safety piece. And phase 4 clinical trials typically happen after the drug has been approved by either FDA or Health Canada. And they're looking at these in a lot of different patients and trying to prove that this medication works. And that's really what they're doing. They're currently, let's see here, there are a couple of clinical trial resources. So if you are interested to find out, okay, well, what clinical trials might be near me, this CanadianCancerTrials.ca is a really good website. I was on it yesterday. There are multiple open clinical trials. It depends on where you're located. It depends on lots of factors that whether or not this clinical trial might be the best for you. Clinical trials can be just something to consider along that treatment trajectory, whether you're lower risk or higher risk MDS. And I'm in Alberta, so I also have the Alberta Cancer Clinical Trials website here, because I'm a bit biased. So there we go. Antibiotics can be used to target and treat infection. It depends as well what type of MDS we're looking at. Is this really affecting those white blood cells more, or is this mostly, more so affecting your red blood cells? So it just really depends on what we're seeing with you specifically. Maybe that's how you were diagnosed, was you were having lots of chronic infections just constantly. So that can be a flag. Additional care, and I put this at the end, although it really should be considered from the very beginning as supportive care. The main purpose of this treatment is to improve comfort and quality of life for anyone diagnosed with cancer, no matter what stage this is or the goal of treatment might be. So there are lots of different things to support care. Managing those symptoms, making sure that you have the proper supports at home, whether that's home care, palliative care, those transfusions as needed, and really making sure that you're on the right treatment path for you. Okay. Forward onto high risk MDS. So if you were lower risk and you either didn't respond to treatment or things are changing in that marrow now, you may move into this category. There are a few different things here. So, we're going to look at whether or not you might be a stem cell transplant candidate. Is there an available donor? These things need to be matched, and it depends on where you're located and the criteria for, they're really going to look at, are you fit enough? Are you well enough for this? And, what kind of response they might expect. So lots of different things with that. So if you are not a candidate for a stem cell transplant, they often standard of care will be azacitidine, which is an immunosuppressive therapy or a cytotoxic agent. And I will get into that a little bit more. And as well, we'll get into transplants. Here we go. So some high-risk treatment options include this allogenic stem cell transplant. And I did mention earlier, there are two types of transplants. There are autogenic or allogenous and allogenic stem cell transplants. Autologous is basically your own stem cells that they remove. They do a treatment to your body, and then they put those cells back in. Whereas this allogenic stem cell transplant is taking somebody else's stem cells and putting them into you. So let's get into that. So there are different criteria. They will look at your age. This depends on each place. So and it also depends on how well you are. So again, we don't want any ageism, but it's kind of just a ballpark number to see, really to compare to, are you that 70-year-old that runs marathons, or are you the 70-year-old that may not, be doing not as fit, as strong, because of other reasons. Looking at really, they just want to make sure that the treatment they give you, that it's going to, you're going to get through it. Yeah, so this is a procedure. As I mentioned, you get the stem cells from somebody else, which to replace your own that have been either destroyed by treatment with radiation or destroyed by high dose chemotherapy. And there is also, for lower risk disease, a delayed stem cell transplant, which offers, maximal life expectancy as long as the transplant occurs before the progression to acute myeloid leukemia. And ultimately, eligibility is going to be decided by the transplant center. And yeah, it is typically the only cure for MDS. Okay. Immunosuppressive therapy. So another drug therapy is this azacitidine or Vidaza. There is a new one. It's called Inqovi, which is a combination of medications. So azacitidine is typically given 7 days in a row on a 28-day cycle at your local or satellite cancer center. It is an immunosuppressive therapy, also known as, chemotherapy or cytotoxic agents. It is used in higher risk disease, and some of the side effects can decrease white blood cells and platelets. So you can, have an increased risk of infection and an increased risk of bleeding. And it's for patients who do get this treatment, it's not the most comfortable. It's multiple injections, usually in the abdomen. And there can be some rash and some itchiness and kind of discomfort with that as well. So this Inqovi is an oral tablet. It's taken once daily on days 1 to 5 every 28 days. And usually with both of these medications, they are monitoring blood work, they're monitoring your symptoms, they're monitoring how you're doing, and you may as well need transfusions or assistance on these medications just to help manage some of those symptoms. There is, with this Inqovi as well, significant drug interactions. So make sure you talk to your local pharmacist. And I do have our pharmacist on the line here, Courtney, and I said I'd give out her personal cell phone number. So Just kidding, Courtney. And it does contain lactose as well. So there can be some, abdominal upset if you are somebody with lactose intolerance. We've touched on clinical trials. We've touched on supportive care. These are the same within high risk treatment options, same as lower risk treatment options. And so with that being said, we've covered the majority of treatments for MDS and some side effects. I'm going to pass it back to Fiona here and Dr. Dwip Prajapati for questions. Thank you so much.
Thanks, Danielle, for all the information there. We do have a couple questions in the Q&A from Jim Cameron, so I'll turn those over to you, Dr. Prajapati.
All right. Good question. So first question is, what does the blood work look like, or what should I look out for if I start transitioning from MDS to leukemia? Excellent question. So it all depends on.
Oh, we lost you there.
Sorry. Can you hear me?
We can now, yeah.
Yeah. So it all depends on your symptoms, first of all, at the time of diagnosis. As Danielle mentioned in her presentation, that MDS can be low risk, high risk. At the same time, at the time of presentation, whether your diagnosis has been made just as an incidental finding where you have yearly physical with your family doctor, and on blood work, they found that you are anemic or your white cell counts are low, your platelets are low, and further investigation leads up to the diagnosis of MDS. And it's on the blood work, on the bone marrow, it shows that your cytogenetics or the chromosome analysis doesn't show any high risk features. And basically you are low risk, you are asymptomatic. And in those patients, you can be just followed up regularly to keep an eye on your symptoms and treat only if need to be. Let's say once you start the treatment, let's say it's because of the low hemoglobin, you're feeling tired, and they start you on either on EPREX or luspatercept, or any treatment to bring your hemoglobin up, or if you are having low white cell counts, they start you on treatment. So at any given time, if you derail from your baseline, so let's say if you're asymptomatic and suddenly you become more short of breath and your blood work shows that your hemoglobin has significantly dropped down suddenly, or if your white cell counts have dropped down suddenly, or if sometimes your physician will tell you that they see an increased number of blast cell in your blood, that's an indication that there might have been some changes and there is a risk of transformation into acute leukemia. So it all depends on what your baseline symptoms are and how fast they have changed or how fast they have progressed. Symptom-wise, that will give you an idea whether you're gonna have any chance of transformation or not. The other thing which again can help is, as I said, the blood work, where if there's a significant drop in blood, hemoglobin or white cell counts, or seeing blast cells. The other factor which is very important, or we keep a very close eye on those patients, is at the baseline when you have a bone marrow biopsy, and if it shows high risk, what we call high risk cytogenetics, means chromosomal abnormalities which are considered very high risk for transforming into acute leukemia, those are the patients we follow quite closely. And if you ask your hematologist, they can tell you what your risk score is. And based on that, there's a calculator which gives an idea about what are the chances of transforming into acute leukemia. So that's most of the time is the best way to determine whether you have any risk of transformation. Now, going back on your other question, which you just posted, Jim, how do I determine the blast level in my blood? Yeah, it should show up on your CBC. So not the regular CBC, but when they do something called manual differentiation, in that they determine out of all the white blood cells you have, how many of them are your neutrophils, how many of them are your lymphocytes, and within that they mention sometimes blast count as well. I practice in Alberta, so we usually see that on the blood work. I don't know in BC whether it shows up or not, but the best way is if you ask your treating physician, they should be able to tell you what your blast level in the blood is, because if that suddenly increase in number, even though you are asymptomatic, does warrant that you need to get maybe a repeat bone marrow biopsy to look into whether you're transformed into or not. So to answer your question, which you ask how to determine whether you are transformed into acute leukemia, it depends on your it depends on your symptoms. So if you are going smoothly, you're doing well, and suddenly you have a dip in your symptoms where you suddenly start feeling significantly tired, catching more infections, having more bleeding symptoms, that's an indication where you need to get your blood work done sooner than the scheduled one. From the blood work point of view, if they see significant drop in your CBC findings, or if they start seeing blast count going up in number, despite being on optimum treatment, that's another thing. And the other thing which is has a more predictive value is at the baseline when you have a bone marrow biopsy, what is your risk score? So you might have heard from your physician about something called revised IPSS risk score, which determines so many factors, and that gives you a score which puts you in either low, intermediate, or high risk category. And obviously, by the name of it, you can imagine that if you are in the high risk category, your chance of transforming into acute leukemia is much higher compared to the other people. Now, the second question by Jim was, you've been on 10 doses of luspatercept, haven't appreciated any benefit increase, but do I stay on it? So no, I would definitely suggest. So as Danielle said, that first of all, you need to understand the aim of your treatment, because the aim of the treatment in MDS is to improve your blood counts and improve your symptoms. It is not to cure your MDS. The only curative intent treatment is an allogenic stem cell transplantation, which is offered only in high-risk patients who are fit enough to go through that, because the allogenic stem cell transplant is one of the most harshest treatment in medicine, which we know. So when it comes to luspatercept or EPREX, first aim is to improve your hemoglobin. So your hemoglobin is improved, but seems like you're not breathing. So there can be so many factors. First factor is if you have any other medical comorbidities, which can be contributing to your shortness of breath. If you have, like, say, underlying lung issue or heart issue, that can cause increased tiredness. Other thing is, let's say prior to going on luspatercept, whether you are requiring frequent blood transfusion, we know that patients who require more than 9 to 10 units of blood transfusion, they are at high risk of what we call iron overload, because every time you get a bag of blood, you get a but you get a big whooping dose of iron, because that's full of iron. Now, the issue with iron is once it gets into your system, there is no way of it getting out unless you bleed. So once iron enters in your system, it stays in your body unless you bleed or you donate the blood. So that's why once you get more than 9 to 10 units of packed red blood cell or blood transfusion, chances are you will have very high amount of iron in your blood, and high amount of iron in your blood is going to make you feel significantly tired. That is one of the common symptom of it. So when your hemoglobin numbers are getting better, but you're still feeling quite tired, then either you or your physician needs to look at other factors which might be causing the tiredness, as I said, including any underlying heart or lung conditions. If you are previously requiring multiple blood transfusion, then they'll need to look at your what we call ferritin level, which is an indirect measurement of your iron. And if it is high, sometimes what we do is we put patients on certain medication, what we call iron chelators, to get that iron out of your system, because the only other way to get the iron out of the system is by giving away the blood, which is not possible in patients with MDS because they're already low in hemoglobin. So the way we get it out of your system is by using certain medications. Obviously, they come with certain side effects, but that's where I think your routine physician can discuss with you. There are different options of doing that. Does that answer your question? Okay, I don't think they can answer that way, but now Susan, I've been taking lenalidomide for 6 years. It keeps me transfusion free. How long might this remain? It can continue. Like, the thing is, the likely reason why you're on lenalidomide is like your MDS is something called MDS with 5q deletion, which is considered as very low risk. MDS and has a really good prognosis. So you can this might be continue to be effective for quite a long time. The best way to determine how long is to determine is based on what's your baseline IPSS risk score. So if you are in the low risk category, your physician can tell you what are the chances of your MDS transforming into acute leukemia. That's where you stop receiving the response. From my experience, patients who have MDS with 5q deletion syndrome, they usually stay in on good response for pretty much lifelong. So the risk of you having any issue down the line is very low. The only time when we start seeing the problem in this MDS patient is if they start developing some extra chromosomal abnormality. So on top of 5q deletion, let's say down the line in the next 2 or 3 years, if your bone marrow stem cells develop some extra mutation, which makes it higher risk, that's where you maybe start losing the response. As long as that doesn't happen, that you should be okay continuing with the lenalidomide. But just making sure that with lenalidomide, you need to look out for the side effects. You must be on blood thinners to prevent the risk of blood clots, because that is one of the biggest side effects. And the other thing with lenalidomide is make sure you have yearly follow-up with your family doctor for cancer screen, because there is very small risk. It's not significant enough to stop the medication, but very small risk of secondary cancers with lenalidomide. So those are the things with lenalidomide you need to keep an eye on. Okay, so Jim, you have iron over, so that's what I thought. Ferritin level is, so usually, ideally the target, I mean, I always tell my patients there are some things which are medically recommended and things which are practically possible. Medically recommendation would be to bring your ferritin level down below 300, because the normal ferritin level for males is 30 to 300. So ideally, we want to bring it below 300. The problem is, as I said, the medications do come with the side effects. So many times we have to readjust our target iron ferritin level. As long as we can bring it below 500, your symptoms should get better. As I said, but ideally should be below 300. If you can get it around 500 or below, you should feel better about it.
If there's any other questions, we'll just give you a minute to type them into the Q&A there or into the chat feature. And
you're welcome.
If you don't see those, you can hover your mouse over the bottom of the screen and they should appear. While we're giving anybody else a chance to type a question in, I'll just mention that our next webinar is actually regarding clinical trials. Danielle is talking a bit about those. We're having a webinar on March 30th about patient-oriented research and patient engagement in clinical trials. So if you're interested in that, you can register on the AMAC website. I'm not seeing any other questions. Last call. Okay, well, with that, I'd like to thank both Danielle Moch and Dr. Prajapati for their time today and sharing all their knowledge with us. And as I said before, we did record this webinar, so you can see it again or look at the slideshow again if you like on our website. That usually goes up within about a week of the session. And please do check our website for upcoming webinars. We'll be having them right through probably till the end of June, and then we start up again in the fall. And we're currently not holding in-person patient support groups, but we do have online patient support groups. There's a Western Canada one, a Central Canada one, and Atlantic Canada. And you can join whatever one is convenient for you. And they're all listed on our website as well. So with that, I just thank our presenters again and wish everybody a good afternoon.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you.